And we now have with us Dr. Norbert Soom from Basel University Hospital. Dr. Soom will be talking about the latest controversies in osteoporosis therapy and give us an evidence-based update.
Dear ladies and gentlemen, the sky above osteoporosis therapy is not as bright anymore as it used to be. Recent studies with good clinical evidence have created results that question former fundamentals of osteoporosis therapy. And these results did not only find their way into our scientific journals, instead they became the headlines in the lay press. And this is the reason why I think we should not only know about the latest results in these trials, we should also know about their interpretation within a broad context. So for this lecture, I have selected these 3 topics that caused the largest rumor. So in the first part of my talk, I will ask the question whether calcium supplementation causes an increased risk for myocardial events. In the second part, I will then review the evidence for the dosing of vitamin D supplementation. And in the third part of my talk, I'm going to address a possible causal correlation between long-term intake of biphosphonates and atypical femoral fractures. So we move to the first part of my talk. Do calcium supplements cause increased risk for cardiac events? Until recently, calcium played a key role in osteoporosis basic therapy. And therefore, the minimal intake is also recommended in national guidelines. And brand new, also we have now an upper level in the latest US guidelines from this year. So even if the numbers differ, most amongst us will pretty much succeed to get this calcium intake by their healthy diet. But our elderly patients, they will not succeed so. And this is the reason why calcium supplements are frequently used by persons aged 60 plus. However, if we look at the evidence was not 100% convincing in the past, because in 2008, Wright found only a modest increase in bone mineral density because of calcium supplementation. And in 2007, Tang only found a marginally reduction of fracture risk with calcium supplements. But to make things even worse, now the calcium supplements are suspicious to cause increased risk for myocardial events. So what has happened? Bolland and colleagues, they have analyzed the risk for myocardial events in randomized controlled trials that applied calcium by means of a meta-analysis. Only trials that were placebo-controlled, randomized controlled trials that administered more than half a gram of calcium per day to participants aged 40 plus, and that included more than 100 participants were looked upon appropriate to be included into the meta-analysis. The results? 5 studies contributed data on the patient level, and they found a hazard ratio for myocardial events of 1.3. The results are pretty similar in those studies that contributed only data on study level, because they found a pooled hazard ratio for myocardial events of 1.27. You question these results? Well, there are limitations in this meta-analysis. First of all, to name, cardiovascular events were not the primary outcome in neither of the studies included. This means the cardiovascular events were not documented in a controlled manner. Instead, they came from self-reports, they came from hospital admissions, and they came from death certificates. However, as all the trials that were included in the meta-analysis, this should not change the results. Second point is that the results from Bolland do not apply for most prescriptions of calcium supplementation, because it is the recommendation to substitute calcium plus vitamin D. And Bolland and colleagues, they have systematically excluded such studies that co-administered vitamin D. So this is why the relevance is also limited. And finally, not to forget, none of the individual trials that were included had proven significant results. So from this, we conclude there is some evidence that calcium supplements may increase the risk for myocardial events, but this conclusion is not true for calcium intake by healthy diet. It is not true for supplementation of calcium plus vitamin D. And having seen the modest benefits from calcium supplementation, a reassessment of the role of calcium in the management of osteoporosis is warranted. What does it mean in practice? In our hospital, we make sure that every fracture patient age 60 plus gets a calcium intake of in between 800 milligrams to 1.5 gram. And only if the patients do not succeed to do so with their not natural food, we then won't consider supplements, but only together with vitamin D. So if you compare our scheme with the latest results, we are well in line with that. With this, we change to the second topic, which is the dosing of vitamin D supplementation. Vitamin D is related to a multiplicity of health benefits, a reduced risk of fall and fractures only be the well-known ones. So what speaks in favor for vitamin D supplementation to reduce fall risk? In 2009, a meta-analysis was published which investigated the efficacy of vitamin D in preventing falls among older individuals. This meta-analysis included 8 double-blind randomized controlled trials that included patients and participants aged 65 plus and who were administered a defined dose of supplemental vitamin D. The studies that were included were grouped into 2 groups. The high-dose scheme, which meant supplementation of in between 700 to 1,000 international units of vitamin D per day. And on the other hand, the low dose, which meant supplementation only with 200 up to 600 international units. The results were as followed. With the high-dose schemes, they succeeded to reduce the fall risk by 19%. Whereas with the low-dose scheme, they did not succeed to reduce the fall risk. So what speaks in favor for vitamin D to reduce the fracture risk? Again, a meta-analysis was done and published which investigated now the influence of vitamin D on the risk of all non-vertebral fractures. This time, 12 randomized controlled studies could be included with more than 40,000 participants, and for each one of them, the individual dosing of vitamin D was documented. Again, the studies were separated in high-dose and low-dose regimen, and the high-dose supplementation again succeeded to reduce the fracture risk by 20%, whereas the low-dose regimen did not show significant results. So, the results of these meta-analyses can be interpreted as follows. There seems to be a lower barrier for the vitamin D serum level. In order to achieve the health benefits, the serum level should be above this lower barrier. And daily administration, according to the high-dose scheme, seems to be a secure and safe way to achieve this goal. In line with these findings, there are recommendations within the national guidelines for daily supplementation of vitamin D in between 800 to 2,000 international units and, again, brand new, up to 4,000 international units in the US. However, in previous guidelines, there was a suggestion to achieve the vitamin D level by sun exposure, which is unrealistic for most of us and also for most of our patients. So this means supplementation is essential. However, we know that such daily supplementation meets bad compliance. And therefore, the idea was born to have a single annual dose of vitamin D administered. And the study was designed to investigate whether this annual dose of 500,000 international units is effective in reducing falls and fracture. The study design, again, was double-blind, placebo-controlled trial. More than 2,000 community-dwelling women aged 70 plus were included, and they were randomly assigned to either achieve the 500,000 international units or the placebo for 3 to 5 years. The results were surprising because they did not meet the hypothesis. In fact, Sanders and al. Found an increased rate for falling and also an increased rate for fractures in the vitamin D arm. So how this could be interpreted, the players in the vitamin D field are not secure so far. The interpretation that could be too much of a good thing is only one of the interpretations. However, this could be also a hint there is an upper barrier in the vitamin D level, and in order to achieve full health benefits, we should keep the serum level below this upper level. So how does this theory translate into practice? In our hospital, we make sure, again, every fracture patient age 60 plus will receive 1,500 international units of vitamin D. And you see, these guidelines, again, are well in line with what has recently been published. So with this, we switch to a third topic, which is the causal correlation between long-term intake of biphosphonates and so-called atypical femoral fractures. Because this issue has attracted so much interest, the ASBMR has introduced a task force. One of the major goals for this task force was to identify major and minor criteria which need to be fulfilled in order to look upon a subtrochanteric fracture, an atypical one. Major features are the fracture region should be in a subtrochanteric region or the femoral shaft. The fracture pattern should be transverse or short oblique. The fracture should be associated with no or only a minimal trauma. There needs to be a medial spike and absence of a comminution zone in the fracture site. Again, all these major features need to be fulfilled in order to look upon a fracture, an atypical one. Minor criteria have been observed to be often found in patients suffering from atypical fractures. These include increased cortical thickness, a periosteal reaction of the lateral cortex, prodromal pain, bilaterality, delayed healing, comorbid conditions, and drugs exposure, not only to biphosphonates, but also to proton pump inhibitors and to oral steroids. So with this know-how, I feel we now are prepared to apply the features on a case-based. These are the standard X-rays of an 86-year-old female. She's claimed pain in the left hip without prior trauma. And on the standard X-rays, there was no fracture line seen, and therefore, because of persisting pain, she finally had a CT scan. And then on the CT scan, a lateral femoral neck fracture and a pertrochanteric fracture were diagnosed. From her history, we took that the patient was known for osteoporosis, and she was put on alendronate 10 years before. So if we now apply the major features to this very case, we have to state the fracture does not lie in the subtrochanteric region, the fracture pattern is not short and oblique, and there is no medial spike. So this fracture would not fulfill the criteria to be an atraumatic one. However, if we switch on the right side, we perfectly see a situation which might be an insufficient fracture in the future, which would then perform all the major criteria. The point I want to make is that strict application of the ASBMR guidelines may be very helpful to define what is an atypical fracture. But on the other hand, too strict application should not lead to underreporting of the incidence. And with this, we come to the numbers that have been published from the task force. They have assumed that if the biphosphonates were applied according to the standard guidelines, that means, for example, according to a fracture interventional trial, that were more than 700 non-vertebral fractures and more than 1,000 clinical vertebral fractures were avoided per 100,000 person years on biphosphonate. So this is the rate of fractures that were prevented. If we compare this with the highest estimate for so-called atypical fractures, which is 100 per 100,000 patient years, then the numbers of prevented fractures would be 7 to 7 times higher than the number of atypical fractures. So the risk-benefit clearly speaks in favor of biphosphonate treatment in such women at high risk to suffer from a fracture. How does this translate into practice? In our hospital, we only prescribe bisphosphonates to such patients that bear a risk for a major osteoporotic fracture of 30% or more within the next 10 years. And additionally, we are well aware of the guidelines of the ASBMR in order not to miss the atypical fractures. So with this, I may now summarize. In the first part of my talk, I have presented evidence that calcium supplements may be the reason for increased risk for myocardial events. However, this does not apply for the calcium that is been taken with a healthy diet. It does not apply for calcium supplements in combination with vitamin D. In the second part of my talk, we have seen evidence that vitamin D plays a key role in the prevention of fractures and falls. To achieve this health benefit, a daily supplementation of at least 400 international units is recommended, with a lot of space for higher doses. And from the third part, we should take the message that the odds speak in favor for biphosphonate treatment in the population at high risk to suffer from osteoporotic fracture. However, that lack of awareness should not lead to underreporting this incidence of atypical fractures. I thank you very much for your attention and looking forward to your questions.
So Dr. Soom, we have some questions for you. Dr. Goyal from India has requested that we answer this question. Which is recommended, vitamin D3 or calcitriol? And is there any harm in using calcitriol to treat vitamin D deficiency?
Thank you very much for this question. In our experience, there has been a change. Previous times, there has been application of vitamin D2 and also D3. The D2 be more common in the US. In the meantime, this has completely switched to vitamin D3, so this might be the future. The calcitriol we use in such patients that show renal insufficiency because they are not capable to convert vitamin D3 to the active form. So we only use the calcitriol with severe renal insufficiency because here we have to take very much closer looks at the dosing. So from my standpoint, vitamin D3 is more secure for the standard patient, but the renal insufficient patient should receive calcitriol.
Very good. So we have another question from Dr. Kobayashi from Japan. Is bisphosphonate enough, or is it better to combine bisphosphonates, calcium, and vitamin D for treatment?
It's a very good question. So in our clinic, we only start the biphosphonates if we have made sure that the patient is vitamin D sufficient. If we apply bisphosphonates in patients insufficient on vitamin D, the drug will not have the full effect. So first, we have to make sure the vitamin D is refilled, and then we apply the biphosphonates. But there is always co-administration of vitamin D plus the biphosphonates. We never apply biphosphonates on their own. So it's always the co-administration, biphosphonate plus vitamin D, and if they don't succeed to ingest enough calcium, then maybe calcium supplements additionally.
Excellent. So we have another question from Germany from Dr. Kruger. Should anti-osteoporotic medications be changed after some time or stopped?
Very good question. Very forward-looking question. In my experience, the rumors we now see because of the atypical fractures, these may be ruled out if we have the patients on anti-resorptive therapy in closer control. So far, it has been more or less the standard to prescribe the drug and then to have it run for years, maybe in a significant amount of patients without further controls. I see in the future that we will have more controls on the bone metabolism. That means we have to see what is the reaction of the patient's individual bone on the drug. And I think this will make the therapy much more safe in the future.
Excellent. So we have another question. What do you think, this is from Dr. Zarita in Ecuador, what do you think about the annual treatment for osteoporosis, and what is your opinion about weekly treatment with vitamin D for osteoporosis?
So this is a very broad scope that is opened with this question. I first announced the annual treatment with solandronate, which has been recently introduced. I think the annual dosing is quite compliant for the patient. We can make sure that the drug is really administered to the patient, but we have to make sure that we do it at the correct point of time. That means after the fracture, we have to wait a certain time until the fracture consolidates. This is because otherwise most of the drug will go to the fracture site and will not distribute in the body. So the less frequent the application of the drug, the more important the correct timing. Whereas the weekly application, this means the application as a pill, this was the routine in the past. We don't know about the compliance of the patients with this way of application of biphosphonates. The compliance was found to be very poor, and I think the time of application per os is more or less over, because also these conditions of sitting upwards, not ingestion, and being fastening for 30 minutes, this is very difficult to perform for the elderly patients. So I see a bright future for the IV applications.
We have a question from Dr. Escalante from Ecuador, and also several others have asked the same question. How long do people have to be on a bisphosphonate therapy to develop an atypical fracture? And does it matter which bisphosphonate?
So with atypical fracture, everybody means there is a typical pattern for these atypical fractures. In fact, I have found recently 4 cases after we have been discussing in depth at the US Geriatric Fracture Course. So awareness of a problem is one thing to see the cases. And only from these 4 cases I can tell there is no typical pattern. In fact, there is no common scheme. So I think what the ASBMR has published so far, this is the best we can get from the case reports and from the case series. For the future, to better identify what are patients at risk, I see a register where all the patients that suffered from such a fracture should be inserted, so we can extract maybe risk factors. So I've seen atypical fractures under our own cases with 4 years of treatment and others after 10 years of treatment. So I think this is only a very rough idea. I think we really have to have more information about bone metabolism. That means the bone turnover. I think this is much more significant than the time of treatment.
Very good. I have a couple of questions here asking when you would use the teriparatide or parathyroid hormone in the treatment of osteoporosis.
This fits perfectly to this issue with the atypical fractures. So each patient that is suspicious to have an atypical fracture and who is on biphosphonate, I will stop the biphosphonate. I will make sure his vitamin D is sufficient, and I will then switch to the PTH. So the PTH, in my perspective, is very indicated in case of atypical fracture, because these patients are at high risk to suffer from another one. And from the other point of view, I see in the future that we will have more change in the therapy principles. That means maybe we run 3 to 4 years with one principle, maybe prevention of resorption, and then we switch to osteoanabolic one, or the other way around. So in the future, I will see more applications of therapeutic principles other than biphosphonates.
We have a question that has come on. If you have a patient with a paratrochanteric fracture who is on a bisphosphonate, would you then change the treatment?
I mean, the change of treatment is recommended if the patient demonstrates failed therapy, and the fracture under treatment may be looked upon as failed therapy. On the other hand, I always explain to the patient, look, the drug I'm going to prescribe to you does not reduce the risk of fractures to 0. It just cuts it down to 50%. So the fact that he has suffered from another fracture does not clearly show the drug doesn't work. But again, I come back to the monitoring of the therapy. If in future we get better standardized bone metabolism information, we can then check, in case of another fracture, what is the bone metabolism at this very moment, and we can then better decide if to continue with the current drug or if to change the therapeutic principle.
Excellent. And I think we have room for a few more questions. Several physicians have requested, how do you monitor the sufficiency level of vitamin D? What does it depend on, and how do you actually do it?
So, in fact, we only monitor the insufficiency level. That means if we get patients referred from nursing homes, we do a basic evaluation of the vitamin D level, and we know then if they are insufficient. There is a broad spectrum if you do the lab investigations of vitamin D. In fact, there is some labs that recommend the serum should be protected against light. Others say it doesn't matter. So we have a shift in between 30% on the vitamin D level. And we are just confident if the patient was insufficient before, we have a refill done within a couple of weeks with high dose, and then we change to a plateau level. And we don't do verification anymore of the vitamin D level because I feel it's of limited interest.
Great. So there's several questions that have come through, including this question from Dr. Ramirez in Chile. Many dental and facial surgeons complain about the use of bisphosphonates because of the reports of osteonecrosis of the mandible. What do you think about this, and how often does this happen? Is this something we should worry about as orthopedic surgeons?
Thank you for this question. I think we definitely should be worried about that. We have to inform the patients because, again, this issue has been published in the lay press, and patients will read about that if they are interested. So I think it's very important that we give information on a scientific basis so the patient feels informed. In fact, again, it's about the same as with the atypical fractures. Maybe this problem has been overestimated, but it has created rumors, and so we have to inform the patient about this complication, and we have to make sure that the mucosa is intact prior to set the patients on the biphosphonates. I think this is the most important thing, that we really take a look into the mouth of the patient prior to a prescription of biphosphonate, and then you are pretty sure.
Is there a specific type of patient who is at risk, or a specific medication of the bisphosphonate class that puts the patient at risk for this problem?
For the atypical fracture problem, this seems to be a class problem, even though most cases reported so far are related to alendronate. But this is simply because alendronate has been the most widespread drug in the past. Concerning the use of biphosphonates and the relation with mucosa defects and jaw necrosis, this is more stitched to the IV application of biphosphonates because it's more common if the biphosphonate is given because of cancer treatment, and these are the high doses, and these are the IV drugs. So ibandronate might be more relevant for the jaw necrosis than the alendronate, but it's only because of the way of application. I think both are problems that are class related.
Very good, and thank you for this very informative and helpful presentation, Dr. Soom. And also